Good morning. My name is Jessica Masgay, and I'm here to present an organizational problem that I identified and have been actively working on addressing during my clinical time this semester. This presentation will explain the lack of an effective patient throughput and communication process, which has had a significant impact on the organization. My goal is to explain the problem and the problem-solving process, as well as share the completed progress to date and the next steps. So since the beginning of fiscal year 19, the Children's Hospital in the organization where I completed my hours was consistently at critical capacity. Many frustrations were expressed from team members about the lack of this efficient process. It did start in the ICU, but had a downstream effect on all other Children's Hospital units and the adult units within the organization. So we identified that there was a lack of an efficient process to move patients through our care continuum, and that this was having a large impact. When we were investigating the significance of the problem and just how large the impact was, we recognized that we were declining many patient transfers. So since the beginning of fiscal year 19, 22 transfers were declined. And as you can see, the number increased each month throughout the fall and winter months. There was an impact on patient care. So the boarding time of our patients in the organization, in the ED, our average boarding time was approximately 4 hours. The average currently, from the time that it takes a patient to arrive to our organization and be admitted to the unit where they would receive the level of care needed, was approximately 7 hours. And our current PACU average boarding time is about 2.5 hours. So we noticed that this was significantly impacting our patients, families, and business, and the satisfaction of all. We recognized many gaps in our process. Our charge nurses were the main source of communication from our units to all supporting departments that had an influence on the patient flow. And information was not always consistent with that of the physician groups who were ultimately making the decisions about patients. So for example, thoughts about a patient potentially being downgraded, which caused a cascade of decisions and process implementation that then might have changed once the physician teams actually rounded and made an official decision, which led to gaps in communication and the actual process, and then the satisfaction and the workflow of all involved. It was also very clear that there was a gap with the clear definition of roles in our processes. So who communicates information and with whom was definitely contributing to the confusion and the frustration and the lack of an effective process. We also heard that there was an opportunity with communication regarding the movement of patients among units and transfers. So looking into this further, our current median time of discharge is about 2:30 in the afternoon. So if that communication could occur sooner, patients could potentially be moved more quickly or be discharged, which would create movement and additional space for patients. So the intervention that was implemented was a Children's Hospital capacity call. And what this call entailed was, it was held 2 times during the day, once in the morning and once in the evening. It was led by our central patient logistics department, and information was shared between the Children's Hospital nurse managers that were on the call for every unit and the physician leaders in every unit, basically every admitting physician in each area of the Children's Hospital. It's very important to note that the initiation of this call was the first time that there was physician involvement in capacity and throughput discussions on this level of collaboration. So the objectives of the information was to ensure that we had a clear, structured, sustainable process, a way to communicate to ensure the success of implementation, and then to measure the impact that this call would have on the ultimate quality of patients, the satisfaction of our teams, and the finance piece in terms of the whole organization. And also, it's important to consider that there are other factors impacting this process. So when the organization is at critical capacity, we wouldn't have the ability to accept patients regardless of an effective process if there truly was no movement of patients that could occur. But part of the goal of this process implementation was to make teams aware that the call would still be beneficial, to keep all stakeholders informed of what was happening, and then to determine if there were any movements that could be made and when, so that we could then accommodate other patients. Minimal resources were needed for this intervention. Mainly, the largest need was human commitment in terms of time and buy-in. So from our key stakeholders, and then we did have a small financial need with the conference line for communication, but also another need and resource was support from administration to enforce the expectations of participation, and that we needed something to improve this process, and that all were expected to collaborate. So initially, the call was working very well. We saw immediate improvement in satisfaction of unit leaders. They felt that there was a plan in place and that resources were being utilized to address the problem that was impacting their daily workflow. However, we did recognize that the unit leaders who had all the information and were the main source of communication were not included on the capacity call. It was the Children's Hospital nurse managers. So a couple changes were made, and charge nurses were named the key stakeholders in the process, and were added to the call to communicate with the physician leaders and the patient logistics department. There was also an assessment of, for the physician leaders and the Children's Hospital nurse managers, there were many meetings throughout the day that discussed these things. So we had to find a way that we could be more efficient and implement a process that would eliminate duplicate work. There were consistently parties that were not present on the call, which could have been from a lack of buy-in and a very quick rollout. But it was known that the stakeholders were needed for the decision-making, or we would not see benefit and the perceived successful outcomes. So that was part of some of the changes that were made as well to gain additional buy-in and ensure that participants were on the call. So our barriers and challenges. During the planning phase, we had multiple perspectives from diverse stakeholders. So each unit, as I said prior, is very different. Everyone has a very different workflow. So identifying a time that a large amount of stakeholders could come together to discuss this was very, very challenging. And also, many stakeholders had a different perspective on what the call should address and ultimately what the outcome should be. So that was a challenge. During the implementing phase, I think the buy-in, as I said earlier, and the commitment from the teams. And then there was also a little bit of a challenge with the technology. So Zoom was initiated during the second phase of the call, and there were some technical difficulties, as many throughout the organization had not used this technology yet. And then during the evaluation phase, we mainly received feedback that what we saw when the capacity throughout the hospital decreased and we were no longer on critical capacity, that the stakeholders would not attend the call. And this was because there was a thought that it wasn't needed if we weren't at capacity. So part of the next phase and next steps will be ensuring that stakeholders understand that this process is important, no matter whether we are at critical capacity or not, because the thought is to be proactive and have a plan in place, and that impacts the patients within our organization, whether we're on critical capacity or not. So our outcome evaluations, now as we go back and we assess the call in its entirety, we're going to look at the attendance on the call. So we've heard the feelings that attendance drops, but we have not been tracking it. So that will be a tangible way of evaluating that. We hope to get continual feedback on the perceived barriers and the challenges. So we plan to send out a survey to the staff, and that way we can measure our satisfaction and how the perceived impact that the process is having. And then we want to look at the impact that we're having. So the number of transfers that were declined, and expanded even into the adult hospital as well, not just our pediatric ICU where this originated. Looking also then at our boarding times, which I had disclosed were high, and our discharge time, which is pretty late in the day, and see if this process has helped to improve any of those. So this work will continue once the semester ends. We really realized how large this problem spans and how many units that it impacts. So we plan to look at the time frame that we should give to really assess if the process has been effective, give us some time to collect data, and then analyze the data. So the unique role of the leader in this process, the main thing was being a change agent. So helping teams understand why this is important, why it was needed, the impact that it was having, what the results will gain for us, the individuals, as well as the organization as a whole. So really helping the teams to understand what this means and what the gains will be. Also the importance of communication, that this will only be successful if we all communicate and talk to each other, and it's for the benefit of the patient. Also facilitation of the meetings to incorporate the new process. As I said, many stakeholders had varying opinions and thoughts about how it should be rolled out and how it should continue. So facilitating those discussions and ensuring that there's collaboration and that everyone feels involved and included and that their workflow is benefiting. Additionally, accountability in terms of holding those accountable to the process and participating. And then the application of evidence and theory. So everyone wants to know why they're doing something and that it's based on evidence that is backing up our decisions that we are making to implement this. The theoretical framework that I associated with this intervention was Lewin's change theory. So we are somewhere in the middle of the unfreezing and moving and transitioning phase. So we never quite left the unfreezing phase. As I had said, we still lack some buy-in. There are still many, many challenges. However, given the urgency of this problem, we moved into the transitioning phase. So hopefully we can work through those gaps and continue to move and transition forward until we will enter the refreezing phase, where we will have a sustainable process that we know has impacted our organization in a positive way. So in conclusion, we lack a standard organizational process for streamlined patient flow and throughput. The greatest challenges were communication and engagement of stakeholders, and the collaboration needed at all times to ensure that patients were being moved in the most efficient manner and that we could accommodate the patients needing our care. Our next steps, so in the literature, there was a concept of a healthcare scribe that helps improve the workflow of physicians and nurses. So that is something that we could look to as well into incorporating as another intervention in this problem that could help decrease ED times because workflow has increased and we can get patients moved quicker. So this is something that could certainly be considered as an intervention in the future. Also something that we want to look at in the future is the impact on our supporting services. So patient transportation, how they fit in this process and impact our goals. Environmental health, we know we can't move patients until rooms are ready for occupancy. So how they are involved and how we can work with all teams and collaborate throughout the organization because it all really impacts this problem. So lessons learned, the span of this problem is very, very large, and there's many resources and stakeholders that are needed to ensure effective collaboration to implement these interventions and ensure success and sustainability. I learned about the strategic thinking and planning that was involved in this process, looking at it in a systematic approach because the span of the problem was so large. I learned how to identify the appropriate stakeholders. You don't want too many people involved, but you need to make sure the right people are involved. And then the work that is needed to make this successful involved a lot of delegation and collaboration. So here you can see my reference list, and I thank you for listening to this presentation. If you have any questions, I'm happy to answer them. Thank you so much.